I really hope this video actually sounds better than it sounds in my ears because I have a very terrible cold. I really hope it's not COVID. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at Croup. If you haven't yet subscribed to the channel, subscribe to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. Drop a like, drop a comment to Zambia and beyond. Let's go. In my previous video I did on epiglottitis. If you haven't watched that, I'll leave a card right here that you can go and click. I'll also leave it tagged at the end of the video, so please go check that out. Remember, when you're talking about croup, you're pretty much talking about a variety of conditions that are going to be causing this peculiar type of brassy-like cough. And you get features such as inspiratory stridor, hoarseness, and respiratory distress, though this may not always be associated with croup. Diseases included in the bracket of the illness include acute epiglottitis, which we talked about, laryngitis, laryngotracheobronchitis, and spasmodic laryngitis. Remember that the differential diagnosis must actually differentiate croup from many other conditions such as diphtheria, which you're going to see a membrane on laryngoscopy, or occasionally with measles. You may also cause croup presenting with angioneurotic edema. Retropharyngeal abscess is another differential to keep in mind, which may cause respiratory obstruction. Same thing with aspiration of a foreign body. So this one here, it's rarely even confused with asthma because of the wheezing that we see. So we'll talk about laryngotracheobronchitis, which is infectious croup. Remember, this is inflammation and edema of the subglottic, larynx, the trachea, and the bronchi. There are two main forms of croup, which are mainly viral croup and spasmodic croup. With the viral croup, this is actually the most common cause of stridor, and it's going to be presenting with various degrees of inspiratory stridor, a barking cough, hoarseness, which is often attributed to the inflammation and the edema in the laryngeal airway or the laryngeal region. It's very common in children aged 1 to 3 years, and it's very common in the late fall and in winter. It has a predilection to male gender with a ratio of 2 to 1. Most of the cases are often caused by viral infections such as parainfluenza virus, especially type 1, being the most common cause, but you may also have other organisms such as respiratory syncytial virus, parainfluenza type 2 and 3, rhinovirus, adenovirus, influenza A and B, as well as Mycoplasma pneumoniae. Bacterial etiology as well as bacterial superinfections are unusual with viral croup. Clinical features are going to include an onset of a gradual but low-grade fever. They may have a predisposing or a preceding upper respiratory tract infection with these coryzal symptoms. I talked about coryza in a previous video. You can click over here to go and watch that video on coryza. Remember also that they're going to have this prodrome for about 2 to 3 days, followed by stridor as well as a harsh barking-like cough. The stridor becomes very evident, especially when the child is upset or they're agitated. Symptoms of croup are going to include things like mild inspiratory stridor, but as the obstruction actually worsens, the stridor may become more marked, and you may also get this suprasternal and substernal or sternal recessions with respiration. There may be features of fever, a barking cough, a hoarse voice which typically lasts 3 to 7 days, and respiratory distress that may occur. So the child may become restless, they may become anxious, they may have this fast breathing, which is often due to increasing hypoxemia. Eventually the cyanosis is going to be appearing, and stridor and cough is going to be worsening at night, especially with agitation. And in some cases, you may see that actually the breath sounds actually become rather inaudible, and the stridor actually begins to apparently decrease. This doesn't mean the child is improving. It can actually be a sign that the child is actually deteriorating. And usually, croup usually resolves over a period of 3 to 4 days. It can be actually divided into mild, moderate, and severe based on the characteristic of the stridor, the presence of recessions, and other features of respiratory distress, as well as the level of consciousness. In mild type of croup, the stridor is only heard when the child is agitated. There are mild subcostal recessions, and the child is often restless when they are disturbed. With moderate type of croup, it's seen at rest. The stridor is often noted at rest. They do have a moderate tracheal tug, and they are anxious and agitated. In severe type of croup, they have a severe biphasic stridor, use of accessory muscles, lethargy, and drowsiness. When you do an anterior radiograph of the neck, you may actually see a steeple sign or a wine bottle sign, where you actually see the narrowing of the upper trachea on this x-ray, and this is actually reminiscent of the steeple of a church. Diagnosis is often suspected based on clinical features, but an x-ray can be done in cases where you are doubting. And the differential diagnosis to keep in mind includes acute epiglottitis, bacteriotracheitis, foreign body inhalation, anaphylaxis, as well as the retropharyngeal abscess. Management includes keeping the child on the mother's lap and handling them gently. At all costs, do not attempt to examine the oropharynx. We should assess the level of severity and manage it dependent on the level of severity. If it's a mild croup, as we already discussed, give them dexamethasone 0.6 milligrams per kg orally, and yes, I did say orally, or an IM injection with a maximum dose of 12 milligrams, or prednisolone 2 milligrams per kg orally as a stat dose, or nebulized budesonide 2 milligrams as a stat dose. Observe this child for 4 hours, and if they are stable and they are well, you can discharge them after 4 hours. For those with moderate type of croup, we generally want to admit them to the acute bay, cover them on dexamethasone and prednisolone, as well as nebulize them with adrenaline 1 to 1000, about 1 to 5 mils, diluted in 0.9% normal saline. And this can actually be repeated every 30 minutes for about 2 to 3 times. For those that have severe croup, you generally even want to admit them to the PICU, the Pediatric Intensive Care Unit, consult ENT surgeons and anesthesia for possible tracheostomy, cover them on dexamethasone and nebulize them with adrenaline, and give them oxygen at 1 to 3 liters per minute. Supportive care is going to be including cool mist and fluids, and of course improvement is also noted when the patients are exposed to cool night air. With spasmodic croup, this usually happens year-round in preschool aged children. It's going to be common among the age of 1 to 3, and there is no preceding coryza. The cause is actually unknown, but is thought to be due to a hypersensitivity reaction, and usually there is going to be an acute onset of stridor, which is worse at night. So the child will wake up suddenly and they'll have this brassy-like cough and this noisy breathing, and the symptoms improve within a few hours. So the illness actually may recur on the subsequent days, and the course is generally benign as the patient actually completely recovers. Remember that spasmodic croup typically recurs and is going to resolve without any treatment. Humidification of the room can actually help when you're nursing such a child. With bacteriotracheitis, this is quite uncommon, but it's a re-emerging cause of stridor. It's where you have this acute inflammation of the trachea. It's commonly caused by Staphylococcus aureus in 60% of the cases, but can also be caused by Streptococcus, non-typable Haemophilus influenza, and in the clinical features, it tends to appear abruptly with toxicity, high fever, mucus, as well as pus in the trachea. Management includes appropriate anti-staphylococcal antibodies and airway support. I really hope you enjoyed this video and learned a lot on croup. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.